Every year in the United States, roughly 300,000 people end up in a hospital because of a broken hip. 300,000, the size of a mid-sized American city, gone after a fall year after year. And here's what most people overlook. The chain of events that ends with a broken hip almost always begins in the feet. Not in the bones, not in the balance organs of the inner ear, in the feet. The second fact lands just as hard. Research keeps showing that a sizable share of people living with chronic lower back pain have a biomechanical problem in their feet that no one ever examined. Because when your back hurts, everyone looks at your back. That makes sense, but it misses the actual cause about half the time. If you want honest, clear health information that goes deeper than what you get in a rushed appointment, subscribe to this channel and hit like. That helps more people find Dr. Waterling and keeps this content going. The goal is 300,000 subscribers, and every single one of you is part of making that happen. Practical checklists and extra health content go out on my Telegram. Scan the QR code on screen right now. Let's start with a test you can do right now. Stand up, close your eyes, and lift one foot off the floor. Just lift it. No tiptoe, no balance pose. Just hold the position. Count the seconds. If you're between 50 and 60 years old and you dropped before 15 seconds, your feet are already losing function. If you're past 60 and couldn't manage 10 seconds, the process is well underway. Under 5 seconds, that's a signal worth acting on today. Gerontologists, doctors who specialize in aging, use this test around the world. Studies have shown that single leg balance time is a reliable predictor of fall risk and independent living in older adults. One standing test tells your body's story more clearly than a stack of lab results. The good news? This is reversible at any age. That's what today is about. Each foot contains 26 bones, 33 joints, and more than 100 muscles and ligaments combined. 1/4 of every bone in your entire body sits below your ankles. Compare that to your hand, 27 bones, and you use your hands non-stop. Typing, cooking, picking things up, turning a key. Your feet get jammed into rigid shoes and largely ignored for decades. The neglect is almost total. Inside each foot, there are not one, but 3 arches. Most people only know about one. There's the medial longitudinal arch, the one that collapses in flat feet. There's the lateral longitudinal arch along the outer edge, and there's the transverse arch running across the ball of the foot under the toe joints. All 3 operate together as a shock absorption system. At walking pace, each foot handles roughly 1.5 to 2 times your body weight with every step. Running drives that to 3 or 4 times. If you weigh 180 pounds, your foot is dealing with somewhere between 270 and 360 pounds of force per step. When any one of those 3 arches collapses, that force travels upward without being absorbed, straight into the knee, the hip joint, and the spine. What holds those arches up isn't bone structure. Bones are the frame. The arches are held by muscles and ligaments. Your foot has more than 20 small intrinsic muscles, muscles that live entirely inside the foot itself. They hold the toes in position, keep arch shape, and feed second-by-second information about the ground beneath you. Try this right now. Spread your toes wide the way you can spread your fingers. In most people past 50, this barely works. The toes either don't move independently or they all clump together and shift as one stiff unit. That's not a disease, that's atrophy from disuse. The brain has essentially stopped tracking those muscles as useful. The sole of each foot contains roughly 200,000 nerve receptors. They scan every surface in real time. Angle, texture, temperature, vibration. That information feeds the brain continuously, and the brain uses it to make constant micro-adjustments to your whole body position. This is called proprioception, your body's awareness of itself in space. When you spend 30 or 40 years in thick-soled shoes, those receptors receive almost no useful input. They don't shut off, but their sensitivity drops. The signal turns noisy. When the brain gets a blurry picture from below, the body compensates. The calf muscles tighten, the thighs tighten, the lower back tightens, all trying to make up for the lost clarity from the feet. You start walking more cautiously. Steps get shorter. There's a slight shuffle. People chalk this up to getting older, but research on age-related changes in leg proprioception, published across multiple peer-reviewed journals, consistently shows that this loss of sensory precision is one of the primary drivers of balance decline in aging adults, and it responds to targeted training. Getting older is not the same as having no options left. Here's how a few degrees of misalignment at the foot wrecks a knee joint over time. Research in biomechanics has consistently shown that even modest inward rolling of the foot during the stance phase of walking, a pattern called overpronation, measurably increases the load on the inner compartment of the knee joint. The average person takes between 6,000 and 8,000 steps per day. That's roughly 3 million steps per year. When even a small fraction of that load is redistributed asymmetrically because of how the foot meets the ground, one side of the knee cartilage absorbs more wear with every single rep. Over 5 years, over 10 years. The damage is so gradual you don't notice it until one morning you can't fully straighten the knee. A well-documented pattern in orthopedic practice looks like this. Once a knee starts hurting, the person unconsciously shifts weight to the other leg, turns the sore foot outward. That compensatory gait starts damaging the second knee. The pelvis tilts a few millimeters to one side. The spine has to curve to keep the head level. Functional scoliosis, not genetic, not congenital, acquired from the ground up, develops. A patient named Carol spent 5 years managing lower back pain with injections, physical therapy, and pool exercises. Some periods better, some worse, never fully resolved. When a thorough orthopedic evaluation finally started at the feet rather than the spine, the finding was clear. Her left foot was rolling inward significantly more than her right. Custom orthotics and targeted foot exercises were introduced. Within 3 months, the back pain had resolved. 5 years of treatment, and the cause was sitting about 8 inches below where everyone had been looking. The chain doesn't stop at the spine. When the pelvis shifts, it subtly compresses the large blood vessels that supply everything below the waist, the iliac arteries and veins. One foot feels warmer than the other. Many people attribute this to varicose veins or age. The origin is often mechanical. Higher still, when the foot loses its shock absorption, the muscles above compensate by tensing. Among the first to tighten are the diaphragm, your primary breathing muscle, and the muscles of the pelvic floor. Breathing turns shallower. The body gets slightly less oxygen per breath. The heart works a little harder. Sleep quality dips slightly. Fatigue sits a little higher. Each of these effects is small. Over years, they compound. There's one more connection worth understanding: the fascial system. Fascia is the thin, continuous connective tissue that wraps every muscle and organ and ties them into a unified network. The plantar fascia on the bottom of your foot connects directly to the Achilles tendon, then to the calf, then along the back of the thigh up to the sacrum, and continues alongside the spine all the way to the base of the skull. One uninterrupted line of tension. When the fascia shortens at the bottom of the chain, everything above it feels the pull. This is why some people get genuine neck and upper back relief from foot massage. It's not mystical, it's structural anatomy. The human foot spent roughly 4 million years developing without rigid footwear. For most of that span, it walked on varied terrain. Rock, soil, sand, and every surface sent rich information upward through the sole. Then, a few hundred years ago, rigid-soled shoes with a raised heel arrived. And in evolutionary terms, a few hundred years isn't enough time for the foot to adapt. Modern shoes create 3 problems, and together they are severe. First, the narrow toe box. Look at the foot of a newborn. Toes spread wide, big toe pointing straight ahead. Now look at the foot of a 60-year-old who has worn conventional shoes their entire life. Toes squeezed together, big toe angled inward, little toe curled under. This is not genetic variation. This is deformation produced by years of mechanical pressure. The muscles that should spread the toes have atrophied because they were never allowed to work. Those toe muscles are the final drivers of each step. When they fail, the stride shortens and weakens. Second, the heel rise. Not stilettos, even the 2 to 3 centimeter lift built into most men's dress shoes and the vast majority of athletic sneakers counts. Elevating the heel shifts the center of gravity forward. The lower back arches to compensate, the pelvis tilts, the knees bend slightly. Over years, the Achilles tendon, the thick cord connecting the heel bone to the calf, adapts to this shortened position and loses length. When you stand barefoot on a flat floor, you feel the pull behind the heel. The tendon can no longer return to its natural length, and that shortening drags on the entire posterior chain: calf, hamstring, lower back. Third, the thick sole. Those 200,000 plantar receptors get insulated from the surface. Researchers at the University of the Witwatersrand in South Africa documented significant structural differences between the feet of habitual barefoot walkers and habitual shoe wearers. The barefoot group showed stronger arch structure, greater toe splay, and a dramatically lower incidence of flat feet. The condition we treat as near normal in modern populations barely existed under natural conditions. After 50, 4 processes converge on the foot at the same time. First, collagen production slows, roughly 1 to 2% per year after the age of 30, according to established biochemical research. Collagen is the protein that makes ligaments and tendons elastic and resilient. As production declines, the ligaments holding the arches in place stretch without fully rebounding. The arch doesn't collapse under load, it just slowly fails to return to its resting height. Second, the fat pad under the heel and the ball of the foot thins significantly. Most people have no idea this pad exists, but it's a sophisticated shock absorber, structured internally more like a honeycomb than a simple cushion. By the age of 60, it can lose a substantial portion of its original volume. Walking without it feels like walking on the bones directly. Morning heel pain, burning under the ball of the foot after long walks, often blamed on a heel spur, is frequently this: a foot that has lost its natural cushioning. Third, nerve conduction in the foot slows with age. The receptors still work, but the signal takes longer to arrive. The brain, which relies on rapid, continuous feedback from below, starts operating with a slight delay. Reaction time slows. Walking shifts from automatic to effortful. You've seen this in older adults who look at the ground when they walk. They're not being careful out of habit, their feet aren't giving them enough information, so the eyes take over the job. Fourth, and this one is critical, elevated blood glucose accelerates all 3 of the above processes at once. According to the International Diabetes Federation, a large proportion of people with prediabetes have no idea they have it. And elevated glucose is actively toxic to the small blood vessels and nerve fibers that keep the foot healthy. Diabetic peripheral neuropathy, loss of sensation in the feet, begins not at overtly diabetic glucose levels, but at the borderline range that many people consider acceptable. By the time a person notices numbness or tingling, the nerve damage is already in place. This is why, if you are past 50, it is worth asking your doctor specifically about your HbA1c, glycated hemoglobin, rather than only fasting blood sugar. HbA1c reflects average glucose control across 3 months and catches slow creeping elevation that a single fasting test can miss. There's also a mechanical factor that accelerates all of this: excess body weight. Every additional pound translates to a disproportionate increase in ground reaction force during walking because of impact dynamics. The arches, the ligaments, the fat pads, the joints, all of it wears faster under excess load. Rehabilitation of the foot works at 3 levels: restoring mobility, restoring sensory connection to the brain, and restoring circulation. Working only one level produces incomplete results. Working all 3, the foot comes back to life. For mobility, start with what's sometimes called the piano exercise. Sit in a chair, place your bare foot flat on the floor, and try to lift just the big toe while keeping the other 4 on the floor. Then reverse. Lift the 4 and keep the big toe down. Alternate. In the vast majority of people past 50, this is initially impossible. The toes rise and fall as a group because the brain has lost individual motor control over those muscles. With 5 to 10 minutes of daily practice, most people regain independent toe movement within 2 to 4 weeks. That's not a small thing. It means new neural pathways are being built. The foot is reconnecting to the brain. The second mobility exercise is sometimes called the caterpillar. Foot flat on the floor, you try to draw the foot forward by curling the toes toward the heel without lifting the heel itself. It looks exactly like an inchworm moving across a surface. 3 sets of 10 to 15 repetitions per foot. This directly targets the deep intrinsic muscles that support the longitudinal arch. Within a month of consistent practice, many people report that the arch feels more defined, because it is. A third movement is the towel grab. lay a hand towel flat on a hard floor and practice picking it up and crumpling it with your toes. Or scatter a few pencils and lift them. This trains the gripping function of the toe flexors, which are essential for the push-off phase of each step. Strong toes produce a more complete, powerful stride. For sensory restoration, a textured massage mat is the most practical tool. Stand on it barefoot for 5 minutes a day. The varied surface, bumps, ridges, uneven points sends a high-density stream of stimulation through the plantar receptors and begins reversing the sensory dullness that has accumulated over decades. If initial contact is uncomfortable, 1 or 2 minutes is fine to start. The plantar skin adapts quickly. If you have reduced sensitivity from elevated blood sugar, use the mat at home on a stable surface rather than walking barefoot outdoors where unseen hazards are a risk. There's a well-established protocol in rehabilitative medicine in Germany, documented in geriatric care settings, that uses textured walking paths through parks, alternating bark, gravel, clay, grass, and water, specifically for patients with balance disorders and post-stroke rehabilitation. The principle translates directly to what you can do at home with a mat. For circulation, contrast foot baths are among the most effective and accessible options. 2 basins, one with warm water around 100 degrees Fahrenheit, one with cool water around 70 degrees. 2 minutes in the warm, 30 seconds in the cool. Repeat 5 or 6 cycles. Always finish in the warm. The alternating temperatures exercise the vascular walls. Vessels open, then narrow, then open again. Capillaries that were chronically underperfused begin to reopen. Modern physical therapy research confirms that regular contrast hydrotherapy improves microcirculation and reduces lower extremity swelling. One tool addresses all 3 levels at once: a regular tennis ball. It's firm enough to reach deep into the plantar fascia, soft enough not to damage the bones. Sit in a chair, place the ball under your foot, and roll it slowly from heel to toes. Your job is to find the tight, tender spots, and there will be several. When you find one, stop. Apply steady pressure, about a 5 out of 10 in intensity. Hold it for 30 to 40 seconds. You'll feel the tension release as the fascia responds, and a warmth will spread through the foot as blood flow rises in the area. Work the entire sole, inner edge, outer edge, center, the ball of the foot. 3 to 5 minutes per foot. Evening before sleep is an ideal time. After a week of consistent sessions, the tender points reduce. After 2 weeks, the foot feels warmer, softer, and more pliable after rolling. Add manual work with your hands. Grip the foot with both hands, one at the heel, one at the forefoot, and gently rotate them in opposite directions, like wringing a towel. Slowly, no force. If the foot feels like a rigid block that won't rotate, that's your starting point. Daily repetition restores mobility between the small bones of the midfoot. Pull each toe gently, rotate it, flex, and extend it. Give the big toe extra attention. Move it in every direction, slowly and deliberately. The joint at the base of the big toe is a primary hinge of the entire gait cycle. When it loses range of motion, the push-off phase fails, the stride shortens, and the foot turns outward to compensate, kicking off the whole cascade again. One specific point worth knowing about: roughly in the center of the sole, in the natural hollow that forms when you curl your toes, sits a location with a very high density of pressure receptors. Applying firm circular pressure here, about 30 rotations each direction, sends a strong signal through the spinal cord to the autonomic nervous system. Many people report warmth spreading through the foot and a reduction in overall body tension after 1 minute of this contact. Research into foot reflexology using functional MRI, including work from Taipei University researchers around 2014, showed that stimulating defined foot regions activated corresponding brain areas, suggesting real neural connections between the plantar surface and organ regulation. That doesn't mean foot massage cures disease. It means the nervous connections are real and the signaling runs in both directions. Saltwater foot soaks offer simple, supportive benefit as well. 3 to 4 tablespoons of sea salt in a basin of warm water, feet submerged for 15 to 20 minutes. Salt reduces swelling, the warmth opens vessels, and a few drops of peppermint oil adds a toning effect. Not a treatment, but a meaningful form of daily maintenance, especially useful on days when the feet are heavy and swollen by evening. This entire system fits into 15 to 20 minutes per day, split between morning and evening. Morning, 2 to 3 minutes on the textured mat after you get out of bed, followed by the piano exercise and the caterpillar, 10 repetitions each, both feet. Total, about 7 minutes. Evening, tennis ball rolling, manual toe work, point massage, and when possible, a contrast bath or salt soak. Another 7 to 10 minutes. No gym required, no trainer required. A chair, a tennis ball, a mat, and your hands. This routine is accessible to a person at any level of physical condition, including someone who can't stand and does everything seated. Custom foot orthotics, insoles made to support the arch, are genuinely useful in specific situations. Significant structural deformity, severe pain on weight bearing, or an already damaged joint. But understanding how they work matters. An orthotic gives the arch external support. When the foot has external support, the intrinsic muscles that would otherwise hold the arch get the signal that their work isn't needed, and they weaken further. An orthotic is like a cast. It solves the symptom while potentially deepening the cause. The informed approach is to use orthotics during periods of significant loading, go barefoot or in minimalist footwear at home, and perform strengthening exercises daily. Support and training together. One without the other is incomplete. And critically, off-the-shelf insoles from a pharmacy are made for a statistically average foot that doesn't exist in real life. An orthotic that actually fits requires either a plaster cast or a computer-based pressure analysis, plantar pressure mapping. If someone offers you a custom insert without measuring your foot, that's a marketing product, not a medical one. Most people past 50 walk in a pattern that bypasses most of the foot's function, landing hard on the heel, short stride, minimal lift, essentially shuffling. In that pattern, the foot performs maybe 30% of its intended mechanical job. Correct gait has 3 clear phases. The heel touches first, softly, the load rolls through the midfoot, and the toes push off at the end. Heel, mid, toes. When all 3 phases are present, the intrinsic muscles engage, the calf pump drives blood upward through the veins, the rib cage opens, and breathing deepens. On your next walk, try consciously practicing this pattern for the first quarter mile. It will feel deliberate and slightly awkward. The brain learns movement patterns through repetition, and once the new pattern becomes embedded, walking feels easier, not harder, and the feet tire less by the end of the day. How old are you? Leave it in the comments below. It's not a throwaway question. The way aging affects the foot changes meaningfully after 50, again after 60, and again after 70. Knowing which age group is watching helps me give you the most relevant information for where you actually stand right now. The ability to walk independently isn't something most people think about until they can't do it. The CDC reports that hip fractures, which are almost always triggered by falls, result in 300,000 hospitalizations per year in the United States, with 1-year mortality in the range of 14 to 36%, depending on age and overall health. Most people who reach that outcome didn't begin with a bone disease or a traumatic event. They began with feet that gradually lost function until balance became unreliable. A heart can be supported with medication. Blood pressure can be managed with drugs. Cholesterol can be addressed with diet and therapy. But walking can't be outsourced to a pill. That's a function that belongs entirely to the body, and the body walks with the feet. There's a story from clinical rehabilitation that is worth holding on to. A 72-year-old man broke his ankle. 2 months in a cast with no weight bearing. When the cast came off, the foot had lost nearly all function. The joints were stiff, the toes didn't move, the sole had no sense of the floor. He was told, reasonably, that at his age this was expected and that a cane was the likely long-term solution. He disagreed. He started the piano exercise, the caterpillar, daily tennis ball rolling, nightly contrast baths. Every day without exception. At 3 months, he left the cane at home. At 6 months, he walked 5 miles without stopping. At 72, after a fracture, not because of extraordinary genetics, because he gave the foot exactly what it needed consistently over time. Start today. Take off your shoes. Put your foot on the floor. Lift the big toe while keeping the other 4 down. If you can't do it, you've just found your starting point. That's where the work begins. A 5-minute morning routine on a textured mat, some toe exercises in a chair, a tennis ball in the evening. This is not a demanding program. It's the minimum viable investment in keeping the most fundamental function of your body working. These steps are worth discussing with your doctor or a physical therapist, especially if you have diabetes, circulation issues, or known foot deformities. They can help you adapt the approach to your specific situation. Everything in this video is educational. Use it to ask sharper questions at your next appointment, not to replace that appointment. If this gave you something worth knowing, subscribe and leave a like. Everyone helps Dr. Waterling reach 300,000 subscribers. More health content, checklists, and practical posts are on my Telegram. The QR code is on screen right now.